Good morning. I'm Hondt, a student researcher at the surgical department of the Amsterdam UMC. Today, I will present the study on minimally invasive liver surgery for perihilar and intrahepatic cholangiocarcinoma, a systematic review and meta-analysis. I have no disclosures. Cholangiocarcinomas are adenocarcinomas of the bile duct with a poor prognosis. Cholangiocarcinomas can occur intrahepatically, perihilar, or distal of the liver. Currently, in liver surgery, the addition of minimally invasive techniques is being investigated. However, for the cholangiocarcinomas, the use of minimally invasive surgery is still very limited. The reasons include doubts about the safety and oncological outcomes of minimally invasive surgery. Furthermore, knowledge of minimally invasive surgery for cholangiocarcinomas is still very limited. The aim of the study is to assess the safety and efficiency of minimally invasive liver surgery for hilar and intrahepatic cholangiocarcinomas. We have conducted a systematic review with meta-analysis. We searched the PubMed, Embase, and Cochrane databases until June 2024. The articles were screened by 2 independent researchers, and all original studies with more than 5 patients comparing minimally invasive liver surgery with open surgery were included. This means that the distal cholangiocarcinoma was not included, as a pancreatic duodenectomy is indicated for these cases. We focused ourselves on the liver surgery. The primary outcomes of this study are the mortality, morbidity, and major morbidity. Our secondary outcomes include operation time, blood loss, and hospital stay. After the primary analysis, a subgroup analysis was conducted on the cohort of the PSM-matched articles, robotic versus laparoscopic resections, and the hepatounistomy cohort analysis. A total of 3,538 studies were screened based on the inclusion and exclusion criteria. 72 articles were selected for full-text screening, and 37 studies were included in this article. Of the 37 studies, 21 were propensity score matched articles. These studies matched patients who underwent laparoscopic surgery with patients who had similar patient characteristics in the open surgery group. In total, 4,863 patients were examined across all articles, with 2,181 undergoing minimally invasive surgery and 2,662 open liver surgery. There were 75 robotic surgeries described in 5 articles. Risk of bias was assessed using the Robbins 2 tool, and no critical risk of bias was found, and thus no studies were excluded. In this study, 24% of patients had a perihilar cholangiocarcinoma and 76% an intrahepatic cholangiocarcinoma. Patients' characteristics were similar between the minimally invasive and the open groups, except for the significantly smaller tumor sizes reported in the minimally invasive group. There was an 11.1% conversion rate to open surgery. Our primary outcome, mortality, was significantly lower in the minimally invasive group. There was a 1.5% reduction, representing a relative risk reduction of 33%. Our second primary outcome, the major morbidity, was also significantly lower in the minimally invasive group, with a 5.5% absolute reduction, representing a relative risk reduction of 29%. We also looked at the secondary outcomes, divided into the surgical and the oncological outcomes. Surgically, minimally invasive surgery showed a significantly shorter hospital stay and less blood loss. However, a longer operation time was observed. Oncologically, there were significantly more radical resections in the minimally invasive group. However, the recurrence rate was similar between the 2 groups. After the primary analysis, we conducted a subgroup analysis. First, we looked at the propensity score matched articles. In this group, we found a significantly lower mortality, morbidity, and major morbidity. Effects were larger than what was observed in the primary analysis. Next, we analyzed robotic resections versus laparoscopic resections. Unfortunately, there were too few robotic cases for a valid statistical analysis. However, trends suggested comparable outcomes between the 2 groups, with a better trend towards laparoscopic surgeries. Finally, we analyzed minimally invasive versus open surgery in cases where hepatounistomy was performed. Here, significantly lower mortality and major morbidity was found in the minimally invasive group, with similar risks of bile leakage between the groups. This is the first systematic review of studies comparing minimally invasive liver surgery with open surgery for the perihilar and intrahepatic cholangiocarcinoma. Compared to previous systematic reviews of intrahepatic or perihilar cholangiocarcinoma, this is also the largest to date, with 4,863 patients included. The second largest review, by Patron et al., looks at the intrahepatic cholangiocarcinoma and included only 9 studies with 562 minimally invasive patients. The study should be considered in the light of some nuances and limitations. First, most studies included were of a retrospective design, with only one prospective study and no randomized trials. This increases the risk of confounding, although no critical level of bias was found. Selection bias was also minimalized as most articles were propensity score matched. Additionally, the exact surgical technique in some laparoscopic studies was not clearly reported. Only 75 robotic operations were described, so no statistical analysis was possible for this subgroup. More research is thus needed on robotic techniques. Finally, the significantly smaller tumor sizes were observed in the minimally invasive group, increasing the risk of bias for oncological outcomes. This makes the results less generalizable. In conclusion, minimally invasive liver surgery is safe for selected patients with perihilar or intrahepatic cholangiocarcinomas, offering potential benefits in recovery and oncological outcomes compared to open surgery. Randomized trials are needed to confirm these findings in groups without selection bias. Thank you for your attention.